For anyone asking, the webinar will be recorded and shared with everyone who's registered. So welcome everybody. My name is Shekufe Zanji from the Early Childhood Action Network. It's my great pleasure to welcome you all to this webinar today, which is quite unique and different than what we've done before because we're really going into a particular program in a particular region and getting perspectives from different stakeholders from the field. So it's my true pleasure. We've organized this webinar with the Aga Khan Foundation, UNICEF, with support from the LEGO Foundation, and also with our partners at the Africa Early Childhood Development Network. Before I introduce the moderator of the program, just a few housekeeping notes. One, if you have any questions throughout the webinar, I encourage you to ask your question in the Q&A and not in the chat box. There's a Q&A box where you can even vote for questions you like. So the more votes a question gets, the more it will bring it to our attention to ask the panelists. Introduce yourself in the chat box, but don't put your questions in the chat box as it will get lost. With that said, I'll introduce Joyce Marangu from the Aga Khan Foundation to turn on her video. She will be moderating the webinar today for us and introducing you to the panelists. Thank you, Joyce. And looking forward to the webinar. Thanks, everybody. Over to you, Joyce.
Thank you so much, Shekufe. Hello, everyone, and welcome to the webinar today. We are discussing the Care for Child Development implementation in Eastern and Southern Africa with experiences from Kenya, Tanzania, and Zambia. So we have developed a series of case studies, and in these case studies, we're documenting the implementation of Care for Child Development approach in various contexts. And so far, we have focused on Kenya, Uganda, Tanzania, and we also have a special focus on Syria as an emergency context where CCD has successfully been implemented. And so we want to see how CCD has supported nurturing care for young children in those particular contexts. And the goal of this series of case studies is to help practitioners and other stakeholders who want to implement care for child development in their local or national settings. So this is a webinar to disseminate some of that information, as well as to highlight the main challenges, the achievements, and most importantly, the lessons learned in the implementation of care for child development. So today's webinars will focus on East Africa region. And I am privileged to be joined by colleagues who I will introduce. I'm happy to introduce Dr. Jill Pope, who is from the LEGO Foundation, who will give us introductory remarks. And she is a senior research specialist at the LEGO Foundation. Thereafter, we have Mnizante Kim, who is UNICEF's ECD Regional Advisor for the Eastern Southern Africa region. And Mniza will give us remarks on the importance of care for child development as a tool for promoting playful parenting and operationalizing the nurturing care framework within the context of the East and Southern Africa region. So I will hand over to Dr. Jill to take us through the next session. Welcome, Jill.
Thank you so much. Thank you for the welcome, and hi to everyone joining us online. I'm Jill Popp from the LEGO Foundation, and I'm really honored to be with you today to hear about the great work that's happening in East Africa. I want you all just to take a minute to think about the last time you did something playful, or perhaps the last time you played with a young person in your life or in your community. And we'll come back to that at the end of my opening remarks. For those of you who do not know, the LEGO Foundation is a Danish corporate foundation with the mission of building a future in which learning through play empowers all children to become creative, engaged, lifelong learners. But how do we do this? It's through our comprehensive initiatives that incorporate evidence, programs, and advocacy that mission is realized. We know from the literature that there is sufficient evidence about the long-term benefits of parenting interventions for children, However, quality interventions don't go to scale, and when they do, sometimes that quality is lost. To support quality at scale, the Playful Parenting Initiative at the LEGO Foundation has 4 main goals. First, to accelerate the scale up of the great work that's going on out there. Second, to invest in implementation science so we can really understand the key ingredients of implementation so that funders, policymakers, and practitioners can make informed decisions. Third, to support greater uptake of monitoring of best practice in large-scale parenting interventions. And then to equip key sector leaders with the knowledge and skills that they need to integrate play-based parenting approaches across different systems. We're currently supporting implementation of parenting interventions and programs that range from mass media messaging about the importance of early relationships and playful parenting to home and group caregiver family education interventions for children birth to 3 that focus on topics, of course, play, health, nutrition, and responsive caregiving, to name a few. This work is being conducted by the great early childhood workforce in Serbia, Zambia, Bhutan, Guatemala, and Rwanda. We knew that these programs were ready for scale, and we're really excited to see the great outcomes that come from this work. Evidence from the Lancet series from 2017 suggests and highlights the significant benefits of investing in early childhood development for learning, productivity, community well-being across the life course. This series highlighted the critical importance of the early years and the importance, among other things, of responsive caregiving, which I'm sure we'll hear a lot about today. We know that encouraging caregivers to engage in stimulation of children aged birth to 3 often includes play, playful activities as a method, such as playing with homemade toys out in your community. Interventions that involve this kind of playful parental stimulation have been found to affect children's language, cognitive, and motor development. Essentially, caregiver-child play can be a great environment for caregivers to really get to know their child's signals and practice appropriate responding. If you think about it, parents and caregivers are really children's first playmate, and therefore they have the opportunity to give them a head start on learning through play that will last a lifetime. I think that all parents need support during their child's first few years. Interventions that encourage play and communication activities between caregiver and children can help to achieve the kind of nurturing care that allows all children to have high quality early childhood experiences. It is clear that global organizations such as UNICEF, as well as parents and caregivers themselves, have a strong desire to ensure that all children have opportunities for high quality playful experiences, facilitated by primary caregivers. In order to capitalize on this momentum, practitioners, researchers, and policymakers have great incentive to better understand the relationship between playfulness and parenting, identify tangible examples, document the potential developmental benefits for young children, and explore gaps in our current knowledge. So now you've been thinking perhaps about the last time you had a playful moment, either yourself or with children in your life. And I want you to maybe take that forward and think about, maybe challenge yourself in the next few days to have another one, have another playful moment with some young person in your community or in your family, or yourself to be playful, either in the work that you do or in your home life. Thank you very much for having me today, and enjoy the rest of the webinar.
Thank you very much, Jill, and over to you, Maniza.
Thank you very much. I hope you can all hear me. My internet has been misbehaving today. I just wanted to, first of all, say good afternoon to all of you. I'm in Nairobi, so maybe I should be saying good evening and good morning to those of you who are in other time zones. I'm so delighted to be here today. And I really wanted to start off by thanking the organizers of this webinar, because we are really in for quite a special treat this afternoon. You know, we often hear from policymakers, from large agencies, from governments about programs. But today, what I think is really great and different is to hear from a parent and to hear from someone, a frontline worker who uses the Care for Child Development approach and tool in their everyday lives. And I think that's actually going to be a really rich contribution we hear from today. I wanted to talk about 3 main points. As many of you will be aware, the Care for Child Development approach has been in existence since I think the 1990s, and the tool was revised in 2012. So in this region of Eastern and Southern Africa, we've been nearly 10 years now implementing this approach. And for me, there are 3 things that stick out. I think first is that this is a tool about the most important relationship we have for early childhood, which is between young children and their primary caregivers and secondary caregivers. And what the Care for Child Development tool and approach does is support us in how we can make sure during those first early stages of early childhood development, there is support for primary caregivers and secondary caregivers in how they engage, stimulate, care for, and love young children. So that's one thing I really wanted to highlight. The second thing I wanted to highlight is how important this tool is, because it really is based and builds on the evidence that just gets stronger and stronger each year and each year. And so, as was mentioned at the start, we see Care for Child Development as one of the tools that supports implementation of nurturing care. But even before the Lancet brought out its series, and even before we had the nurturing care framework, we had the Care for Child Development approach, which looks at children really in their holistic sense. So thinks about their health, their nutrition, their safety, their security, how to support their parents, and how to really build in stimulation and play as a key component of child development. And so the fact it builds on that evidence is a second strong point I wanted to highlight. And the third point I wanted to highlight is just how versatile the Care for Child Development approach and tool is. So you will hear today from a parent about how relevant that has been in their lives. And then you will hear from implementers from civil society and also from government on how the tool has been used at the national and subnational level. Even for some of our agencies like my own as UNICEF, the Care for Child Development approach has informed what we put out as program guidance globally on early childhood, on infant and young child feeding, and on the approach to child development more broadly. So you see, it's a tool that really can be used across many partners and in many different ways. And I just want to end with thinking about where we move forward to from now, and after we hear the great examples from the different countries and different partners and different perspectives, something to bear in mind is, what can we do as a global early childhood community to take the Care for Child Development approach to a more systems level? So how do we make sure this approach is well financed? How do we make sure it informs all our policies, all our programs, all our training, all our tools? And how do we make sure we use this as a way to measure how well we're doing for young children and their families? So just a few guiding opening remarks and thoughts for us as we move forward with the rest of the webinar today. Thank you.
Thank you, Anisa, for that. At this point, I would like to remind you that if you have any questions, you can put them on the Q&A tab at the bottom of your screen, and that we will be addressing the questions at the end of the presentations. So for this next part of the webinar, we have presentations from 2 panelists. First, we have a presentation from Josephine Ferla. Josephine is a senior ECD program manager at the Elizabeth Glaser Pediatric AIDS Foundation, or if you like, EGPAF. And Josephine's presentation is focused on the role of collective society, civil society action in advocating and implementing care for child development within the Tanzania context. After that, we will have a presentation from Ms. Given Daka, who is an education specialist in ECD at UNICEF Zambia, and her presentation will focus on how a partnership between government, UNICEF, and the civil society helped in addressing gaps in policy and practice through integrating care for child development within the existing systems. So over to you, Josephine.
Thank you, Joyce. And thank you all organizers for the opportunity for EGPAF to have this platform, recognizing that there are also other partners who are implementing care for child development. So it's a good platform for us to continue sharing experience within Tanzania, but also across the other countries as well, in East Africa, but other parts as well. So my name is Josephine Fella, as already introduced. I work for Elizabeth Iglesias Pediatric Aid Foundation here in Tanzania. Good morning, good afternoon, good evening, everyone. So I'm going to share a brief experience in terms of our work on care for child development. And I think I would consider as probably maybe considered different or unique in terms of our work with the health system. Just to give a quick background on EGPAF, it's a USAID-based organization working in about 19 countries. And EGPAF is more recognized in terms of intervention when it comes to HIV and AIDS, especially on prevention of HIV transmission from mother to child. But also EGPAF Tanzania, we work with the Ministry of Health. It's rather quite a long name of Ministry of Health, Community Development, Gender, Elderly and Children. And apart from HIV, we also focus on other services, including TB, family planning, and reproductive and child health. And our role as EGPAF is more in terms of technical support to facilitate access to quality services, operational research, which also inform evidence on advocacy, but also capacity building at different level we work with, from national level to the health facility. We are also funded by Conrad Hilton Foundation in terms of integration of early childhood development services within the existing services. Obviously, one of the aspects you consider is that when you look at children who are HIV, they are more exposed and hence they are more vulnerable in terms of reaching their developmental potential. But in our case, EGPAF, we reach all children through health facilities, which I'll talk about a little bit later. So EGPAF works in 6 regions of Tanzania, the ones which are showing there on this slide, the dark red. And one of them is Tabora. And within Tabora, we also have the early childhood development integrated within the health facilities, where we've worked in a number of health facilities. We've done training in terms of TOTs. We've trained 250 healthcare workers, community health workers, but we've also reached plus 300,000 caregivers of children under 3. And this is since 2016 program where we had started. So I had mentioned that EGPAF, we are not directly implementers, but rather we work with government. And this is the Ministry of Health, but also we work with the Ministry of Local Government. This is PRIGE. And working at all levels. So starting from the national level, our role, obviously, when you have a project, is introduction for projects to be accepted. But in this case, where care for child development was a new package in the country, and for it to be accepted and approved to be used in a health facility, it had to be adapted. So EGPAF, as we are working in Tabora region, but we're also working with the national level to advise in terms of how can the package be working, can be adapted. We are working within the ministry, both Ministry of Health and Ministry of Local Government, PRIGE. We have key personnel. So these are the ECD focal people who we've been working with. And one of them, Dr. Bundala, who is coming from Newborn and Child Health Unit. Unfortunately, he wasn't able to attend. But also we have colleagues or key personnel from Social Welfare Department and also the local government ECD focal people. So these have been actually our champions who've been working with while we are continuing building capacity, but also our strong linkages between us and the community. There is in the region level, so in this situation, we are talking about Tabora region, which we've been working with. We're working with a team, the government team called RHMT. So this is a regional health management team. And that has a combination of specialists. So when you talk about nutrition officer, regional social welfare officer, when you talk of reproductive and child health officer, they're all based in this part of the team. So we had to orient them in terms of the care for child development, but when it comes to planning, budgeting, ensuring that their supervision tools incorporate aspects of the responsive caregiving and early learning, so they're incorporated. This is the team we've been working with at the regional level. And replication to that, at the district level, there is also a council health management team. So it's the same specialist, but at the district level. Here we had to train as TOTs, which I had mentioned, the 20 TOTs. They're coming from the CHMT members. They're the ones who are responsible in terms of supervision, mentorship, and obviously receiving report from health facility and ensuring that the activities which are being provided there are of the quality level. The implementation is taking place at the facility level, where through the trained TOTs, then they train the healthcare workers, who then provide early stimulation responsive services through the routine integration of other health services, but also the community health workers who are based in the community, but they are attached to these health facilities, they are also trained. So community health workers who are trained on care for child development, they work with the community leaders in terms of identifying children who are under 3, but also those who we consider who are at risk. For example, the children with malnutrition, children who are orphans, and link them to the health facility. We have a referral component, which is both ways. So from community health worker, when they identify a child with developmental delay or any other risk like malnutrition, they refer them to the health facility, but at the same time, health facility ensure that they link those children with the community health worker, so they ensure they receive appropriate services, including home visits. So our role really has been in terms of providing support and capacity at all levels to ensure that responsive caregiving and learning aspects are well integrated within the system. So when you go into much more details that, for example, in a care for child development, we have one-to-one counseling. So the health providers are expected during routine services in a HIV clinic, in RCH, in the pediatric ward, they are integrating those messages in terms of play and communication with the health. So when doing vaccination, they're doing weighing, the same as group counseling where we have health talks which are happening. So ensuring that whether it's health providers or community volunteers, when they're providing health talks in terms of nutrition, health, they also integrated the aspect of play and communication. We are using existing support groups. So in this case, we have HIV positive mothers, mother-baby pair who come to the health facility once a month, for example, to collect their medication. In addition to the health services they receive, but also the aspect of play and communication. We've supported these health facilities which we work with to ensure that they have either physical space, because some of the facilities don't have physical space when it comes to ECD corner, but ensuring that they have locally made play materials, where we had worked with social welfare to ensure that they train these health providers, but community health workers to ensure that locally made play materials are available, but also decorate, provide resources to decorate the walls, so to make it more interactive, so that when parents and children are in the class, or they're in the facility, they use that space for play and interaction, other than just sitting and waiting for services. Through home visits, we have, as I mentioned, community health workers who at least conduct a home visit monthly to the household of children under 3. And this community health worker, majority of them, EGPAF had a program in terms of maternal, neonatal, and child health. So expecting that the trained community health workers, they integrate responsive caregiving and early learning aspect when they conduct home visits. So when they conduct home visits, they are not expected just to provide aspect of ECD, but also integrate the aspect of health and nutrition. One aspect we had picked up, which we had adapted in the care for child development, is aspect of safety, because many household or cases we're actually experiencing of accident in a household. For example, fire hazards, children burn themselves, or there's open water places. So we had to ensure that the package actually incorporates. So when community health worker gets to the household, also they're able to assess the environment and advise the caregiver. The aspect of play materials, when we did our baseline, there's very few play materials, especially reading aspects like books and stuff like that. So aspects like that, they're also being encouraged by community health workers to ensure that parents are able to develop their local materials to encourage play and communication. So our community health worker, Carrie, we had modified the counseling checklist and put it in the format of a flip book, so to encourage more like interaction between community volunteer, but also caregiver to really get an aspect what are we talking about. We had to come out with the videos as well, which demonstrate play or communication. What exactly does it mean? So for parents to actually pick those aspects, age appropriate play materials, and also reporting forms. So for example, the number of households which have been reached, what messages have been provided, if there's any referral which has been provided to the facility, so we're able to track down. So I was asked to talk about facilitating factors that lead to successful government buy-in, because now the government has really started incorporating the aspect of care for child development, which I mentioned like previously. So I think one of the main factors which EGPAF we are very proud of is the way we are working within government structures. We are not implementing a parallel program, but this is within. We are training health providers who are government employees. We are using health facilities which are government structure. And also the platform which is being used being health facility actually provide opportunity for scale, but also reaching many children, even in rural areas where the government is still there. We've been using opportunities for review of national documents. So for example, now the government has been able to incorporate in the under 5 growth monitoring, we've been able to incorporate the aspect of play and communication in the booklet. And also for parents to be able to monitor their child development milestones. Previously, the card was just like this, the one with the green and red, but now at least we have additional aspect where caregiver, because the booklet is being provided to each parent to take home. So actually provide opportunity for the parents to see some messages, even those who can't read, at least there's a pictorial messages for them to see. I should recognize that in addition of working with Ministry of Health, but we also this work has been of partnership with UNICEF, Aga Khan Foundation, who also implement care for child development in other parts of the country. So we all bring our experience from the field and really advocate to ensure that the government has a care for child development incorporated into the guidelines and obviously the package when you are doing the adaptation to ensure that all aspects from the local context within Tanzania are being incorporated. So it was a teamwork at the national level, which is something we should really appreciate. EGPAF had mentioned earlier, our planning, our implementation is through local government. So when it comes to, for example, aspect of budgeting, mentorship, supervision, we've been doing it jointly, and that has been an opportunity in terms of building capacity of government employees, but also we've been able to identify aspect of opportunities. For example, as they're doing their local budgeting, then we were able to identify areas in which they're able to incorporate aspect of ECD as well. For example, they plan for budgeting now. So there are some councils that have started allocating resources for that. And that's something which has been built up gradually. And it's just something proudly to see. One thing to also recognize is that you had it to be a learning process, because when you have a package new to the country, being incorporated into the already existing structure, it was something which we had to take a process. So there are some changes we had to do. Among them, for example, the counseling checklist was quite long for the health providers, so we had to modify that. I think my time is coming to an end, I'll go quickly. In terms of challenges and mitigation, I have mentioned them. So when you're working with government structure, there are issues, for example, the staff shortages, like health providers, and hence we had to identify other means in terms of ensuring that care for child development is being provided within health system, because we really know that health providers, once they provide these messages, is something which is being accepted and really appreciated. So if, for example, ensuring that community health workers are able to also provide counseling, the obviously priority of other health services, which is something which is understandable, but ensuring that this is something which is being managed, reviewed by the local government, then hence brings that accountability among health providers as well. Obviously, so supporting the aspect of counseling is not coming naturally. Most of it has been teaching. So we've been reviewing up our training packages to ensure that we're incorporating that the videos we've been developing. Aspect of identifying, we've been picking up a number of children with different issues, but where do we refer them where there is less or minimal or low resources or few specialists? And this is something which we are continuing advocating to the government to ensure that these children are being supported while we're continuing ensuring that other services like responsive caregiving are being provided. And obviously lack of national indicators which restrict accountability, where health providers, they don't feel like motivated if there's nowhere they're reporting to. But this is something which now is being incorporated into the national plan, which is going to be launched soon. So what we would have done differently is really to be realistic when you're working, for example, in a low resource platform. So you really need to expect to have your expectations for quality dosage. More practical lessons, I had mentioned that, but also mentorship to the mentors that we had expected, that supervisors and mentors, they know what they're doing, but this is something which really needs to be supported and for them to understand the difference. The aspect of demand creation is very important. So we are really probably focusing more in terms of supply, but when it comes to demand, for parents to actually demand when they go to a health facility, I need to get the service in terms of responsive caregiving is something that needs to be looked at. But we also use other platforms. So for example, media, which we've really noticed that something really helps in terms of improving the knowledge. So finally, the Ministry of Health, we've noted there are a number of things which they have already done. So incorporation of ECD, the Care for Child Development into the ECD plan, I had mentioned the under 5 booklet, but also some councils are incorporating the responsive caregiver, I had mentioned also. But what we also still continue needed, as Maniza had mentioned, political will, funding of the national plan to ensure that scale is reaching more children, come up with more quality standard in terms of ECD services, so to ensure it's not just access, but also quality services. Introduction in terms of pre-service and in-service training, demand creation, and also expanding care for child development into other entry points like nutrition, child protection, creches. Thank you, Joyce, for listening to me, everyone. Thank you.
Thank you very much, Josie. And with that, we will move on over to Given Daka for the next presentation. Welcome, Given.
Hello, just a minute, just trying to open up. Gosh.
Joyce, while we wait for Given to get loaded, I just wanted to remind participants, if you can kindly put your questions in Q&A. There's also an option to vote for questions. So if you have someone else who's asked a question you can vote for it. And do not put your questions in chat because we will miss it. And if you're going to write something in chat, please select all panelists and all attendees. Given, are you ready to go?
Not yet. I've got a challenge with can you show my presentation from that end?
Sure.
Yeah,
Joyce,
because of connectivity issues. Yeah.
No problem. Joyce or Radhika will share your presentation right now.
Thank you.
Or I can share it in just a second.
So while we're waiting, everyone go over to the Q&A chat box and read the questions that other people have popped in. If you have answers to it from your own experience, you can type an answer yourself and you can vote for a question you really want answered as well. So everyone, while we're waiting, please go over to the Q&A and just pop in and take a look at what your colleagues are asking the panelists. Okay, you're ready to go.
Right, I'm ready to go. Thank you. Good morning, everyone. Good morning, good afternoon, and good evening. So my name is Given Daka from UNICEF Zambia, and I just want to share the Zambia experience with regards with the Care for Child Development and how we have leveraged partnerships in addressing the policy and practice gap through the integration of CCD in systems. Okay, so if you can move on. Hello. Right. So can you just push the presentation to the left? It's cut from my end. Okay, thank you. There are two. Sorry, the presentation is not really showing from my end.
Given we see it, so I think it's okay.
Okay.
Yeah.
All right. So there are two key drivers of the CCD rollout in Zambia, which I would like to share. One of the critical drivers of the CCD rollout in Zambia has been the high-level engagement of key government stakeholders. And the launch of the Lancet ECD series in 2016 and the Nurturing Care framework in 2018 both affirmed government commitment for ECD and really sort of generated buy-in for the CCD. Then the second key driver of the CCD rollout in Zambia has been the multi-sectoral coordination and collaboration with key stakeholders. The ZECTAN platform has been instrumental in sustaining collaboration across sectors and also the knowledge exchange. And the collaboration with NGOs and government stakeholders has also enabled the rollout of the Care for Child Development across the different districts. Zambia has over 110 districts across 10 provinces. And what we've seen is that different partners then are running and implementing programs in different districts and using the Care for Child Development. The coordination across 4 ministries leading to the establishment of ECD Multi-Sectoral Technical Committee at national level. What has actually happened is that the sustained engagement involving 4 ministries has subsequently led to the establishment of the ECD Multi-Sectoral Technical Committee. So with regards to partnerships and the multi-sectoral coordination, we've seen ZECTAN play a very critical role initially, and then subsequently, this has led to the establishment of the ECD Multi-Sectoral Committee at national level and the district ECD Multi-Sectoral Committees who are both supporting CCD at different levels. Now, there are about 4 key strategies that really have influenced or have been used to upscale CCD in Zambia. One is the integration of ECD in policy programs and services across sectors, which really is facilitating the move to scale. The second is the capacity building of frontline workers to support the CCD rollout. And the third strategy has been the rolling out of the CCD as part of a broader package of interventions. And this is Zambia has been using the Caring for Child's Healthy Growth and Development in the rollout of the CCD. And then the fourth strategy has been strengthening the delivery of ECD and Care for Child Development at community level. And in my next slides, I'll be able to elaborate on each of these strategies. Okay, now coming to the first strategy, strategy 1, which is the integrating ECD and CCD in policy, programs, and services across sectors. This strategy, as I said earlier, really does facilitate the movement or moving to scale. So in Zambia, ECD and also leveraging on the CCD has been integrated in the following: the National Health Strategic Plan, which is just the 2 examples that I have put there, and the Education Sector Plan. And also in service delivery. It has been integrated in reproductive health services, the sick child and well child services, early childhood education. And this integration involves the revision of service guidelines. For example, the nutrition guidelines, the IMNCI guidelines. This year we have targeted to work with the Ministry of Education to revise the ECE standard guidelines and incorporate the elements of the Care for Child Development. The Ministry of Health recently in Zambia has developed the Maternal and Child Health Handbook with ECD milestones, which is, and this handbook is currently under piloting with the support of the Lego Foundation. We've also seen government incorporate ECD-related indicators in the health management information system. For example, indicators such as caregivers who've been counseled in ECD, CBVs who are trained in ECD, or households with age-appropriate toys. So this is all part of the integration of the ECD and the CCD in policy programs and services. And ongoing, we are looking towards incorporating CCD integration in alternative care programs under the social welfare services. And I've already mentioned the work that we have set for 2021 to incorporate this in the ECE standard guidelines. And I think of critical importance is the development of a national multi-sectoral ECD policy and strategic framework whose process has commenced, and the integration of ECD in the national frameworks for scale up through system strengthening approach. So the support that we've been receiving from the LEGO Foundation is actually facilitating the integration of ECD and the care for child development in national frameworks across the sectors. The other strategy has been leveraging on existing large programs. We've seen this happen with the Scaling Up Nutrition Phase 2, the SUN 2, and also previously this was incorporated in the MDGI health program, and also components of this have been integrated in the Global Partnership for Education, early education program, which is has been forwarded by the government of Zambia for consideration by the Global Partnership for Education. So the strategy number 2 is really focusing on the capacity building of frontline workers to support CCD rollout. Our experience has involved cascading care for child development training to community-based volunteers and service providers, starting with a core team of trainers and then cascading at the national level as well as at the district level, and then cascading these trainings to the community-based volunteers. Then the other strategy that we have put in place is the integration of ECD and care for child development into national training systems, the training of nurses, teachers, and social welfare. And this strategy presents great promise in terms of creating a sustainable approach to human resource needs to sustain CCD rollout. As we speak this week, we are collaborating with the Ministry of Health with support of the LEGO Foundation to incorporate and develop modules in the national nurses training curriculum. So of course, in terms of elements that we still need to address are the revisions which need to be made to the CCD trainings, mainly in the way of focusing on simplifying the content with key messages and making it the materials more illustrative to respond to the capacity levels of the community-based volunteers that we are working with. So the third strategy is the rollout of care for child development as part of a broader package of interventions. I did mention earlier that the government of Zambia's position in terms of CCD rollout has been to include this as part of a broader package of interventions, and they are using the care for child's healthy growth and development, addressing areas of play and communication, feeding, prevention, and responding to illnesses. And of course, this caring for child's healthy growth and development comes with a full package that is the trainings and the caregiver counseling materials. Our experience, if we had to share the experience, is that the play and communication is the weakest link of the 4 pillars which require more attention. And the reason why government has gone for ensuring that this is part of the broader package is also to address some of the adversities that children face. For example, Zambia has very high stunting levels. So complementing the care for child development with other key messages around feeding and nutrition is critical. Then the strategy number 4 is the delivery of care for child development at the community level. Now in Zambia, our experience is that the care for child development at community level uses 3 pathways. 1, the touch points via existing service delivery platforms across the sectors. So in health and also in education. And then the second touch point is at what we call INSACA, or a community, which is essentially a community-based ECD parenting hub, which provides integrated services and group parental counseling. And then the home counseling of caregivers delivered through a network of community-based volunteers. And the partnership of the various partners that collaborate with government do involve or work within these kind of three main pathways for delivering a CCD at the community level. And then at community level, the Care for Child Development counseling materials are used, but there is some flexibility across the partnership. That is, partners are working with government, where partners do adapt as needed. And this adaptation or enhancement includes additional content to Care for Child Development, or inclusion of more illustrations, or use of supplementary materials such as videos, storytelling, inclusion of radio content, or complementing this with radio content, etc. So we do see this kind of flexibility in the way the partners deliver the counseling at community level. Now, the Zambia experience in terms of the challenges that we have experienced, the issues of responsive caregiving and early stimulation needs, consolidation in the programs in terms of enhancing their effectiveness. If you recall, I did mention earlier that if you look at the caring for child, the 4 pillars of the caring for child's healthy growth and development, that component related to responsive caregiving, play and communication is the weaker component. Then in terms of the CBVs being able to work that and deliver this at community level. Then the other challenge is the monitoring and evaluation of outcomes from the Care for Child Development implementation, changes in caregiver behavior, and child development outcomes. So the whole area of M&D is an area that, from Zambia's perspective, also needs to be harnessed. The opportunities that we foresee or that we experience is that this global, regional, and national momentum, which has been created around the nurturing care for ECD, can be leveraged for increased resources and programming for scale of ECD and CCD. And we have seen this contributing to where the progress that has been made. The current process in Zambia of developing of a national multi-sector ECD policy and strategic framework for Zambia is a fantastic opportunity to enhance responsive caregiving and early learning. So to sum up just the lessons that I would like to share with all colleagues that are on this webinar, based on the Zambia experience, is that the government buy-in, our experience is that working with government and government buy-in has been a gradual process, which has required sustained engagement between government and partners, and gradual understanding of how ECD and Care for Child Development fits into the sectors. So the sustained engagement of government and collaboration between government and partners has provided a gradual process where we have increased government buy-in. And then the other lesson is that the incremental approach in Care for Child Development rollout has worked well, and also leveraged on drawing lessons from implementation. So the implementation of partners and also the incremental approach by taking advantage of opportunities for integration and then moving on with those opportunities has actually worked well, and is gradually moving Zambia towards the development of a national ECD framework. So I think this is one key lesson. Take it bit at a time, and then to benefit a broader perspective as you move along. And then the third lesson that I would like to also to share is that our experience has also shown that having a core team of champions within government and partners has sustained the momentum around care for child development and has actually facilitated the progress to date. We have seen initially a core team of dedicated partners collaborating with a dedicated team of government partners, and this is now has created and sustained the momentum, which is now bearing fruit. Then the other lesson is the focus on training of frontline workers, a cadre of frontline workers that can effectively deliver care for child development. Issues around training, issues around supervision, monitoring and supervision of the frontline workers is critical. And then finally, the global momentum around the nurturing care and the partnership opportunities that this brings forth has improved the feasibility of Zambia to scale out the care for child development. And we are fortunate that we have had some opportunities to receive support from organizations or partners like the Lego Foundation, which is really being leveraged to scale up the integration of ECD and CCD in Zambia. So thank you very much. I hope I'm within the 10 minutes.
Thank you very much, Given. You're beyond the time limit, but we appreciate the comprehensive overview of the progress made in Zambia in regards to implementation of care for child development. So thank you very much for that. For our next presentation, we have a special opportunity today to listen to two individuals who have interacted with the care for child development at the front lines. And first, we have Christopher Wanje, who is a community health worker based in Kilifi, which is within the coastal region of Kenya. We also have a parent, Mrs. Mwanamkasi Ali Said, who is one of the caregivers who has participated in the Care for Child Development intervention conducted by the Madrasa Early Childhood Program in Kenya. I welcome Naima Adam from the Madrasa Early Childhood Program to lead us through the next phase of the discussion, which will focus on the two panelists' experiences with the CCD approach and how this has impacted their everyday life. Naima is the lead program officer for community development at the Madrasa Early Childhood Program in Kenya. And we will have a translation bit by Mr. Omar, who's also based there. So the floor is yours, Naima.
Thank you very much, Joyce. Good morning, good afternoon, good evening, everyone. Habari yako Bwana Kalenga, asante sana kwa kuweza kujumuika na sisi katika kikao hichi.
Naima is welcoming Mr. Christopher to this platform. Welcome.
Mimi Snautu na nashukuru kwa kufika aidha hawatichi vile.
Is responding to the salutations and is appreciating for having been invited to this event.
Bwana Kalenga, Kenya ni nchi moja ambayo ina mikakati mizuri sana ya kuimarisha afya ya jamii, yani community health strategy. Nyinyi kama wahudumu wa afya ya jamii, hebu tafadhali tueleze ni vipi mliweza kuwasilisha mafundisho yale ya malezi na makuzi kwa watoto, yani care for child development.
Kenya has an elaborate community health strategy under which community volunteers work. Could you please tell us what role you play as a CHP in delivering care for child development?
CHP uliohochera elimu ya ufundi ya CCD ama ya malezi na kucheza na watoto, waamua kwenda nyumba kwa nyumba ili kushauri alezi hali ya kusasiga na kuzungumza na hoho.
Immediately after receiving the CCD training focusing on counseling of parents on blame and communication, we as CHBs embarked on conducting home visits to identify caregivers with young children and started talking or taking them through discussions on the importance and how to play and communicate with their children.
Pia kala unatembea kwa community groups ili kwa kusanya hamwenga na kuwashauri hali ya kusasiga na kuzungumza na hoho.
As part of our CHD work, we organize and conduct monthly community dialogue sessions to discuss health issues affecting the communities. So we started integrating play and communication discussions and sessions within this and received feedback from parents on how they are progressing.
Pia ikala ni shughuli ya ukale hundahala ripoti kula pa ara adezi ripoti ziratu ambazo zinalola maendeleo au hali wasasigavyo na hoho na kuzungumza nao na kuzihirika kaheza mikutano yehu ya CU ya Gongoni ambayo hunaihenda kila tarehe 15 ya mwezi na hao wanukala hanachawehu ambaye ndo kala hunamwekira zorko.
I would also carry out periodic reporting on progress made during home visit activities. We would then share these reports during meetings at the health facility, that is Gongoni, and new ways of addressing challenges. We would discuss and embrace them. We also shared and celebrated success made with the intervention, within the intervention. How did members in your rural community in Kilifi receive the CCD messaging and activities?
Jumbe hizi hulizihirika kazi za arezi birwani mishangao ukala mpanoni kuna ukale hundasasika na hoho na kuzungumzana hata hore kwenye mimba na hoho atite. Sasa wachikala wanamba pana hii si kawaida ya kwehu mtu kaza kuzungumza mimba na mtu ama mnahala kuhara mambuga chizungu muhurehere haha sino gago kaugamanya. Kwa hivyo kuchiamua walikanzehu wa vipingoni ambayo ni kikundi cha CHV ambao wamepata mafunzo gaga CCD na mbele kuchiwalika hamenga chawehu wachirea CHV mwenga na mlezi mwenga alikala gago gahenda na yufau. Kwa hivyo walihokuza wachiza sagala na chila kikundi cha atwehu na kuwaeleza ujerino.
Reflecting back, it is interesting how they initially dismissed the whole concept as they thought it was foreign and far-fetched from their day-to-day realities. I mean, how could you play and talk to an unborn child in the womb? People would think you have gone mad. It was not but our culture. Luckily, our neighborhood community health, that is Vipingo, had received the same intervention sometimes back before us through massive care. So we organized and invited CHBs, one CHB, a parent who had benefited, and a child to come and testify. They listened and asked as many questions as they had.
Pia kwa sababu umeendelea kusaa kubali hali kachiomba sababu zingine zokala. Sasa sino hatumafikiri Walio chilama za chafu ndauka ukatafute. Naweza usasige na ho. Patikala wanaendelea kusita kabisa kukubali. Lakini sisi hutafuta njira hutamba tafuta njira badala mpaka wapate wawa na mpaka uzungumze nao mpaka watu wegaratu waligona washauri.
Due to poverty levels in the community, some were worried that play and communication with their children would mean spending more time at home with their children and off their daily economic activities. That enabled them to put food on the table. They see that hungry children cannot play. So we had to see how best play and communication could be done with those constraints. As CHVs, we would meet, discuss, and come with adaptations to make the interventions meaningful and relevant to their circumstances.
Katika yale mafundisho, je, uliweza kubadilisha kitu gani ili kuhakikisha haya mafundisho yamefanya kazi vizuri kwenye kijiji chenu na jamii imeipokea vizuri?
Mr. Kalenga, what kind of adaptations did you make to the intervention to ensure that community accepted it?
Ili kuwawahi waipate elimu ya kusasiga nao na kuzungumza. Kuchamba baba vyazi sasa wanahusu anao akulu basasige na baba atite.
We requested parents to involve other siblings and other available family members who interacted with the children on a daily basis so that they could also play with the children as much as they could when they were away, but encourage them to make time every day for themselves.
Pia tunapendekeza dispensaries na kuhala vikundi vya na kuhala vikundi vya mame kuvisagaza na kuvishauri hali ya kucheza na nao.
As CHPs also integrated play and communication in prenatal and postnatal health talks at the health facility. CHPs would group parents according to the ages of their children and demonstrate to them how to play and communicate with their children.
Yeah. Uchijeza kutafuta njira nyingine, uchamba hundenda paka kwa machifu, hundenda na mabaraza kama machifu, na uchifika haratu, hunda wa grupu wa ni mame, na huwa shauri kuzungumuza na kusasiga na nao. Pia hao, pia uchamba hunda wahenda keherima grupu, ili kama grupu, waweze kuzitengezera vifaa ambavyo wenda sasiga na hoa. Na pia kutunga maira ambazo ganasifu sana ino hali ya CCD ama kucheza na kuzungumza na watoto.
Apart from disseminating CCD messages through dialogue sessions, we extended this to chiefs barazas, that is local administration, where we were given platforms to talk to our caregivers on matters of CCD. We composed songs and performed whenever we had social gatherings. We had material development sessions where parents were grouped according to the ages of their children and asked to develop different materials for their children.
Shukran sana Bwana Kalenga. Pengine katika ile hali ya kuwasilisha ile elimu, kuna ugumu fulani na changamoto fulani ambao mulizipitia na wazazi wa kike na wa kiume ili kuipokea ile elimu vizuri. Hizi changamoto pengine ilikuwa ni zipi na mulikabiliana nazo vipi?
There may have been some challenges in convincing community members in a rural setup about this new approach when you are starting out. Did you face any challenges while dealing either with male or female caregivers? How did you address these challenges?
Naima. Hakika lazima kupata matatizo kidogo hali ya kuhelika uji kwa sababu ulipofika kula majumbani kuona ani mami ajine tayari kuwachero ujumbe katika kubana shida. Lakini sasa shida ajine japokuwa wale wana shida, lakini shida hasa uliyopata tukaweza kulika wapata ni baba. Kwa sababu caregivers ani baba wale wakauka wakenda kazini, kwa sababu ndio wasomi wakenda kazini, lakini wachiza kula kazini sio na watafuta, lakini wabandombo la kero mazumbani wende waka hende starehe za usijine.
Delivering information and counseling the female caregivers was not difficult as such. The male caregivers were hardly available as they were breadwinners and socialization at different places after work. We had to inquire from their wives and we stressed them to their social places where we talked to them.
Okay. Challenge ambayo wewe unaipata ni kukala ani baba ajine wele kababaruhusu achao kabisa kushiriki hiza mazungumzo gaga ya kustasiga na kuzungumza na hoho. Kwa hivyo itikana inabidi kuwalikire cha pia aze na aweze kuzungumzana.
Some men caregivers were simply resistant, even to have their wives participate. So we requested for a support from our seniors, from the health facility, that is CHA, who helped us in convincing them.
Ni mabadiliko gani ambayo umeweza kuyashuhudia wewe mwenyewe kuanzia hii elimu iweze kusambazwa?
Did you notice any changes in the community after you began delivering CCD? What were these changes?
Mabadiliko ambayo tuliyaona ambayo hata vile roho na gona ni kwamba viazi sasa wanaweza kuzitengenezea vifaa vyao vya kucheza na wao wakitumia vyombo vya chipevu.
The changes that we are witnessing now is that our parents, who are the caregivers, are now able to develop materials for their children. They collect resources from within their reach to develop play materials.
Pia kitu kingine ni kwamba viazi sasa wanaanza kusasigana wao tototo na wanaraha kwa hivyo.
Now our caregivers are busy playing. They are playing with their children, whether born or unborn, and they are happy as they bond with their children.
Pia kuna uhusiano baina ya CHV na arezi na arezi sasa wanafurahi ila tu vihendo hata tu wanao wahendago wanahamirwa kabisa na hiyo hali kwa mabadiliko ambayo gakala. Kwa hivyo nina tafufi pia CHV unahamirwa na caregivers nao wanahamirwa kwa mabadiliko ambayo yanaendelea mali.
Both the CHVs and the caregivers are happy on what is happening in their community. The caregivers are playing with their children, they are communicating with their children, and they are developing materials for their children.
Asante sana. Pengine la mwisho la kutuagia unalipi la kusema?
Rangisha mimi ni kwamba nafurahi ukala nakali alipa haha nakaribishwa haha ili nisumurire mweriri la tusasiga na kuzungumza na hoho kwa niaba ya CHV ya Gongoni CU. Nashukuru na naomba sana.
I am appreciating for this opportunity given to me to represent my fellow CHVs in Gongoni and talk about CCD to the world. Thank you. Okay, now we are changing, or we are having our next representative, who is Mwanamkasi. Mwanamkasi Ali will be talking on behalf of the parents who benefited from CCD. Madam Mwanamkasi, welcome, and we are happy to join us in this platform. Welcome. Ms. Mwanamkasi, please tell us how a normal day looks like for a woman or a mother who is a primary caregiver in Kilifi in relation to caring for the child.
Kweli, kwa wazazi wengi wa Kilifi wanapoamka asubuhi kutayarisha vyakula kwa watoto wao, wakawatayarisha, wakala, wakaenda zao mashule. Kwa wale ambao wanabakia pale nyumbani kushirikiana na wazazi wao katika zile shughuli kama kufua, kuosha vyombo, kufagia. Wale watoto wa chini ya miaka mitatu wanapoona wazazi wao wanafanya vile, na wao kuchukua vile vifaa kama kufagia, wakasaidia nao, japo hawajaweza kufagia vizuri. Pia kazi zinazopatikana kule Kilifi, kuna kazi za kuchonga fagio, kupiga makuti, kuteka maji. Sasa wazazi huenda katika shughuli zile tofauti tofauti na pia kujihusisha kwa vikundi, na baada ya hapo wazazi wa kule huenda zao mashamba. Wanapokwenda kule shamba kufanya kazi zao za ukulima, baada ya hapo wakatafuta kuni, wakabeba, wakaja nazo nyumbani. Wakifika nyumbani wanatayarisha vyakula, na iwapo watakuwa wameenda kule shamba, mara nyingi wengine hubeba watoto wao migongoni wakafanya nao kazi, wengine huwachukua watoto wakaweka vivulini na watoto wenzao wakiwa wamebebea vifaa tofauti ili waweze kucheza. Na wanaporudi nyumbani wanapumzika wakiwa wanaandaa vyakula vya jioni, wanakula. Baada ya hapo wengine huelekea kulala, lakini wengine huendeleza zile shughuli zao za makuti na fagio.
A normal day for most women in my rural village includes waking up, preparing breakfast and children for school, cleaning and feeding younger children who are, so some of them are school-going children and some are not. They engage in small income-generating activities such as making of brooms and traditional thatch for houses. Preparing lunch for school-going children because they have to go back for afternoon classes, that is. Going to the farm, fetching firewood and water in the evening after coming from the farm. Preparing and serving families supper, prepare material for small businesses following day. And then they go to some of them go to bed as the others embark on their finishing up on their economic activities. So most of the time, mothers with young children would do this with their babies on their back. And some, like for instance, those who work in the farm, they leave their children under the shade as they play with the play materials that they have carried for them from home. If lucky, some of these children are left to play with their older siblings at home. You are one of the hundreds of parents who participated in CCD, play and communication counseling sessions by the community health volunteers. Kindly describe to us how these sessions took place.
Kwa kweli mafunzo yale niliyapokea mimi kama mzazi. Lakini kwa kule Kilifi kuna ili group la CHVs ambazo lilikuwa likitembelea vijijini kuja kutupa mafunzo. Sasa wana CHVs waliponitembelea mimi kwangu, wakati huo wakinitembelea nilikuwa na ujauzito wa miezi 8 wa mtoto wangu wa kwanza. Hapo walipofika hapo sasa wakanipa mafunzo ya kuzungumza na mtoto akiwa tumboni, japo sikuwa na uelewa ule kwa wakati ule. Wakanielimisha na nikapokea vizuri mafunzo yao.
The CHVs visited us in our homes to counsel us on the importance of play and communication. By then I was 8 months pregnant. So they told us and demonstrated to us practically on how we would practice play and communicate with our children, whether born or unborn.
Pia hawa CHVs walikuwa wakiweka mikutano na kutushauri sisi kama wazazi tuende kule kwa ile mikutano na watoto wetu. Sasa tulipokuwa tukifika kule, walikuwa wakituelimisha na kutufunza namna ya kutengeza vyombo tofauti tofauti vya kucheza na watoto kwa kutumia mikono yetu wenyewe, na kutu groups kwa kutu groups na zile age za watoto wetu.
We also attended community dialogue sessions organized by the CHVs and meetings organized by the local administration. Here, we were counseled and taught on how to develop materials. We were grouped according to the different ages of our children. We developed materials and played with our children.
Na pia hawa CHVs walipokuwa wakitutembelea majumbani kwetu, walikuwa wakituhusia kwenda clinic mara kwa mara. Na sasa tulipokuwa tukifika kule clinics, walikuwa wakiomba ruhusa kwa madaktari ili wapewe nafasi na wao ya kuzungumza na wazazi. Sasa tulipokuwa tukifika kule, tutatoa vitabu vyetu vya clinic. Katika peji moja kuna michoro pale ya mahusiano ya mtoto na mama. Sasa tukifika pale, tukifungua zile peji, wanatufundisha jinsi ya kuwa karibu na watoto kwa kupitia zile picha za vitabu.
Since I was pregnant, 8 months pregnant, I had to attend prenatal clinics. At the clinic, our CHVs would, during the health talk, that is, would integrate the health talk, would integrate CCD information in the health talks. They would advise us and counsel us on matters related to CCD. They would refer us to our clinic books, which had some pictures showing how mothers play with their children.
Sorry to interrupt, Naima. Sorry to interrupt, but we only have 2 minutes remaining. So sorry to interrupt, but yeah, just if you could wrap up.
What are the most important things that you learned?
Kwa kweli nilijifundisha mambo muhimu kwa sababu kwa wakati ule mimi tayari sikuwa na uzoefu wa kuzungumza na mtoto akiwa tumboni, lakini nilipopata yale mafunzo nilijua kuwa ukizungumza na mtoto wa tumboni you respond, na pia wahisi kuwa uko karibu zaidi naye, kwa sababu unapomshika na yeye huwa yuatamani kukushika japo hawezi, lakini yuaonyesha ishara.
I learned that play and communication makes the child active and strengthens the bond. Even to my unborn child, I learned that when I talk to him, I talk to it and interact or communicate with it, it moved. So that kept me close to, it strengthened the bond.
Pia niliweza kujifunza kuwa kwa kupitia yale mafunzo niliona kuwa hata vyombo vya nyumbani vinaweza kutumika katika kumpa mtoto vitu vya michezo, kama vile vyombo vya plastiki vinapovunjika, unapoviweka vizuri vile, mtoto ukitaka kucheza nayo unaweza ukampatia akaendeleza mchezo wake kwa kutumia vyombo vile, tofauti na kununua.
I learned that I can use materials I have within my household when playing with my child, and can also develop materials from the local available resources than buying commercialized play items.
What difference does this intervention make in your life and the life of your child? Kwa kweli mafunzo yale yamebadilisha mtoto wangu, kwa sababu ule uchangamfu ninaomuona nao amekuwa mchangamfu zaidi kuliko watoto wale ambao hawakupata mafunzo.
My child, ever since I started implementing this, my child has been very active and is very outgoing.
Na pia amekuwa karibu zaidi na mzazi wake wa kiume, amekuwa na mazoea zaidi na ukaribu naye, hata wakati anapomkosa kuuliza, kwa sababu yule mzazi naye wa kiume huwa akifika nyumbani uchukua time yake akashughulika naye yule mtoto kupitia michezo ya picha na michoro.
My child is also attached to his father, who is my partner, that whenever the father is absent, the child asks for him. Whenever his father comes back after work, they sit together, read, and they read pictures and stories. Thank you.
Thank you very much, Naima, for that wonderful moderation and for the discussion. Tunashukuru sana Bi Bwana Mkasi na Bwana Mwanje for your presentations. Asante sana. So we move over now to the Q&A section. We would like to go over the questions that you have raised during the discussion. Do you want to take us through that, Shikufe?
Thank you, Joyce. Since we only have about 8 minutes left and we see that people have voted for questions, first of all, a big thank you to all the panelists. It's been such an energizing and exciting webinar to hear voices from all levels. So that's really amazing. But just to really take us, there were over 60 questions asked, so it's going to be quite a task for the last 8 minutes. It seems like people really have questions about measurement. So let's just kick it off. Let's ask questions about measurement. I'm gonna just read a few different questions that have been asked about measurement, and then I'll ask the panelists to respond specifically. So there have been questions about what sorts of measurements, tools are you using to measure both the level of parent engagement and behavior change, as well as child. So that's at the child and parent level. And then the other question on measurement that has been asked is how do facilities report, or how are you measuring actual implementation? Are there tools that you're using to monitor that? So at the implementation level for that. And if you have any general comments on challenges around measurement and what strategies you're using, and I invite all the panelists, Maniza, Jill, because I know Jill works on research, Given, Josie, please just unmute, jump in, and provide a few comments about your experience with measurement in your programs. Okay, I will call on you. Given, go for it. Okay, Josie, you unmuted, go ahead.
All right. Okay. Thanks. So in terms of our own implementation, how do we report? Yes, I recognize. I would just want to immediately say that that's a challenge. So because we're working within the health system, who they already have their own reporting mechanism. So obviously we had to come up with a list of indicators which needed to be reported by, for example, community health worker or health providers on a number of, for example, caregivers who have received ECD messages, responsible caregiver early learning messages, or number of group counseling which have been facilitated in terms of the messages, but also the community health workers, the household which have been reached. We also use mix in terms of looking at the aspect of parenting behavior, but also looking at availability of play materials in the household. But mainly this one is focusing on the research. Currently, we are conducting a research which will be out towards the end of June, and we'll be able to share, and that's based on the intervention which we've been doing to actually see it in terms of change of behavior of caregivers, but also improvement of skills toward community health workers based on the tools which we've been able to identify. We are almost launching our national multi-sectoral early childhood development program. This is a national package, which within that has got a result framework looking at all aspects of child development from 0 to 8 years old. And that's very exciting because you actually know then for that case, we're actually going to have a dashboard in terms of the ECD, and the ministry through the support from UNICEF, they've actually already started showing interest of some of the indicators to go into the national system. So that's quite interesting, but at the moment it has been a challenge in terms of indicators and reports. Thank you.
Thanks. Thank you. Jill, go ahead.
Yeah, I can say that it really depends on the different projects, the different countries that we have. For some, they're using the home inventory. Others, they're looking, other countries that we're working with might use the MDAT or ages and stages, and also maybe at Endline looking at the new tool from the WHO, the GSED. Yeah, and some countries are using the CREDI. So it just depends on the country and what work they had already had, what pilot data they maybe already had, what's already been validated, what they've used, what tools have already been, you know, they've had collaboration on with the government system perhaps, and want to continue that with our implementation research projects. So those were just some, but I'm looking now at our measurement inventory, and it just seems a few of them are using the home, ages and stages, GSED, tools like that. We're also doing qualitative and quantitative. So there are some focus groups that are happening and talking with different key informants and people within the organization, the workforce. So, you know, not just looking at validated tools, but maybe also doing some focus groups to really understand the experience. So.
Thank you. Given, did you have anything? And given there was a specific question directed at you on measurement as well that said, they were asking about if there are any indicators on responsive care that you're doing with the CCD as well. And there were questions around that. But anyways, over to you on measurement.
Okay, thank you, Shekufe. So as I mentioned earlier, I had indicated this as one of the challenges that we have. And that is an area, the whole area of monitoring and evaluation, and is an area that really needs to be strengthened. Now, as I mentioned that for the Ministry of Health, they have 6 indicators. So this has been included in the HMIS system as well as the community management information systems. So there is now information that is being collected from the level of starting from the community level through the CBVs. You know, how many caregivers have they reached with ECD counseling. So these indicators really focus on on the ability to meet the caregivers, to reach the caregivers with critical information. We yet have not sort of included the aspect of the behavior change component. To what effect are they then also influencing behavior change? Now, at the programmatic level, at the program level, we do have indicators that we're working with that also includes additional methods for collecting that data, some qualitative aspects of collecting data through observational, through focus group discussion, as part of the LEGO program, Playful Parenting program that we have, which has very defined set of indicators at the level of the frontline worker, at the level of the caregiver, and then at the level of the caregiver outcome level. But within the government indicators that have been, it's really around, at the moment, around how many caregivers have been reached, how many with critical information on that include care for child development, key messages, and how many frontline workers have been trained to deliver these critical messages. So I think at the moment we're working at it from those two levels, that is at the program level and what we are implementing at the community level, but at the same time supporting government to scale up and roll out the M&D based on those indicators. Then for the national framework that will be developed, that is being developed, that also includes a component of developing a monitoring and evaluation framework. Thank you.
Thank you, Given. I know this is the end of the webinar. We're right at the hour. I know participants are staying on. We still have nearly 163 people that are still on, and they want to hear more from the panelists. Panelists, do you have about 5 or 10 more minutes to spare so that we can answer maybe a few more participant questions since we had so many? Just give me a thumbs up if you're able to stay. Yeah? No, Maniza can't stay. 5 minutes only. Okay, great. Given you're able to stay, Josie, you can stay for just a few more minutes? Few more minutes. Okay, all right, let's get to it really quickly then. Okay, so the next question, we had a lot of questions about the community health workers, and it would be great, Naima, if we can hear from Christopher on this question. There was a lot of questions about how do you motivate community health workers? Are there stipends given to them? Given weaknesses in the community health services, how are you, what has been your experience with using community health workers? And then also the one question that said, in practice, health workers are good at counseling on child health related issues rather than child development, play and communication. How have you worked to improve counseling? So a lot of questions around community health workers. How do you motivate them? How do they stay motivated, and so on? So any comments from you on the workforce? And again, Naima, it would be great to hear from Christopher if he's still around as well, since he is a community health worker. Given you unmuted yourself, go ahead.
By mistake. Anyway, yes, I think I did respond in the chat on the issue of how can we improve on the training or the work of the community health workers. What I think from our end, what we are trying to do is really to simplify, because what we've noticed is that there is a capacity gap between the key messages and the capacity of the community-based volunteers. So simplifying the messages so that they understand and are grounded in a few critical key messages, and also making the tools that they're working with more illustrative. Then the other comment, I think, is also to ground some of this work in in existing practices in the communities that can be leveraged, so that, you know, the community health based volunteers can also already identify with some of the things that are within their communities, in terms of getting to understand the key messages around care for child development.
Hi, Shakufe. Could I just come in because I have to drop off in 1 minute? I think this comes to the heart of the issue I was raising in my opening, and the measurement does as well, which is about how we adopt a much more systemic approach to the work we're doing. It is, I think, irresponsible and not very strategic to think we dump all this work on community health workers when we know in many countries they're not professionalized, they're not well remunerated, they're not part of a system. And so I think we have to ask ourselves, what are all the entry points between, if we're talking about health, the health system and families and young children that we can exploit to full effect to implement things like care for child development. So when we look at our antenatal care system, our postnatal care system, our child growth monitoring, our immunization system, like how well are we using all those platforms? In some ways that will fall on community health workers, but there's a whole plethora within the health system that we have to work with. So I think if we're thinking about the workforce of the health system, how we capacitate them, how we finance this area of work, how we monitor what we do, how we make sure the whole training system speaks to this. For me, I think that's the way we have to reflect. And there are many countries. Zambia has been mentioned. We know in Tanzania, we know in Malawi, we know in Mozambique, Kenya, where people are trying to think much more about approaching this in a health way. I think if we think about labeling and dumping everything on community health workers, that's unfair and that's just not sustainable. So I just wanted to end with those points. And thank you all.
Thank you. Josie, Josie or Christopher, either of you, go for it, Josie.
Yeah, thank you. I think Manisa is raising a good point, but also when you look at the cadre which you are most likely to be able to reach a household, for example, in the community in Tanzania, most likely they are community health workers. Obviously, yes, I agree that we are trying to find a different mechanism to make sure that care for child development does not just focus on a health facility, because of obviously being overwhelmed. So I'm looking at other entry points. So for example, in Tanzania's case, the Ministry of Health is looking at establishing creches, for example. So how can we make sure that things like creches are also being able to be reached? Wherever existing community support group, for example, savings groups, also we have that platform where we could make sure that we are making sure that the care for child development is being integrated. The aspect of technical capacity, I think Given has talked about, but I think one thing which I wanted to add on as well is the mentorship between the community health workers themselves. So pairing them with something which has really worked well in terms of peer, community health worker to community health worker, something which has really helped in terms of themselves to be able to really pick up those concepts which we've been introducing to them. And it's something which we'll definitely be able to encourage for it to continue. I think one thing which I wanted to say also, the Ministry of Health and PRI here in Tanzania, they've developed an operational guideline for community health worker. First, to be able to identify all volunteer cadre in the community, because there are different cadres, the community health workers, the community case workers. So to actually give them the same title, but also to identify different mechanisms in terms of their motivation. So there could be allowance, but what else can community be doing to be able to support the community health workers? So even where we're working in Tabora now, we are closing the project, but we've had to develop a handover plan. I know one of the questions was being asked here is what is sustainability plan? Our sustainability plan, one of the aspects which I had talked about is that already the councils, they've already doing planning and they're allocating budget in some of the activities to do with the care for child development. And among those activities, one of them is how are they going to motivate the community health workers to ensure that they're actually being motivated. So obviously this is something which we are working on, but we do expect that within working with the local government, there are a lot of opportunities for it to be used to be able to facilitate and ensuring that activities are being sustained within the existing system. And I think that's something which we'll be interested to follow and we'll be happy to share later. Thank you.
Thank you, Josie. Naima, is Christopher able to respond? Naima?
Yes. I was just briefing Christopher regarding the question around motivating factors. And one thing that Christopher has shared with me is the fact that he comes from a community which is resource disadvantaged. And as a human being, or them as CHB as human beings, they appreciate that anything that comes their way to support in development of the community is something that they value most. So the fact that the Care for Child Development training came in their way, so they were able to acquire knowledge and skills, and seeing that they're taking the caregivers from one level to another is something that kept them moving and going, and motivated them to continue working with the community health unit, but also working with the Madras Early Childhood Program in implementation of the intervention. So that's it from Christopher.
Thank you. And we'll just end with one final question for all panelists about male caregivers and how to increase both engagement and investment. It was identified as a challenge, and we'd love to hear from both, from all the programs, but also from Christopher and Mwanamkasi as well, if they have thoughts about that as well. So just to end with that question. Josie, Given, if you have any thoughts on male caregiver engagement, Josie, go ahead.
Yeah, so I think one of the, yes, it is a challenge in terms of male involvement. And this is something, especially when community health workers have been conducting home visits, has been a challenge. But one of the advantages we have, for example, when it comes to health facilities, for example, a pregnant mother is actually expected in the initial visit to go with their partner. So that's something which has really helped us to be able to reach both mother and father during the ANC visit, where they will receive counseling in terms of health-related issues, but also when it comes to responsive caregiving and early learning. So using that platform, I think has really helped continuing providing those messages. But even now, as community health workers conduct home visits, they would provide counseling to both mother and the father. I think initially when we started, probably hadn't emphasized a lot in terms of father involvement as well. And obviously with cultural aspects as well, fathers didn't expect to be involved in those kind of activities. But eventually, I think they picked it up. And even when you look in our report, I think the male involvement is something which has really picked up. It's something ourselves also, we realize that, so when it comes, for example, the videos we've developed, the posters we've developed, we really ensure that we involve fathers as well in those activities and messages we've developed. And maybe that's something which has really encouraged. We used champions as fathers champions who, for that case, are able to share the experience with their neighbors, with other fathers, proudly coming to the health facilities, carrying their children. That's something also might have contributed to the increase, but definitely since we started our program to now, you can definitely see the difference. And also, I
think we lost Josie. Given, do you want to jump in?
Yeah, maybe just to say that one way that we've also been addressing is to engage the traditional leadership in the communities to reach the male caregivers. Yeah, so like the chiefs in terms of the community mobilization and community engagement.
Do you want to know them? Don't worry, don't worry.
Naima, can we hear from, can you your side?
Okay. Thank you, Kalenga. Thank you, Madam Kasi. Also, two suggestions from our CHB and parents based on their experience, but again, based from our working with them. One is they're sharing that sufficiently capacity building, the female caregiver can provide a good avenue or platform to attract the male caregiver. And then the second one is identifying strategic entry points for the male caregivers within the community. Maybe it's difficult to reach them through the one-on-one counseling, but can we identify strategic entry points and then sensitize these male caregivers?
Wonderful. Thank you. I think with that, we will close this webinar. Just to say that, there were over 70 questions asked. We also noticed there were a lot of questions asked about inclusion and children with disabilities. We make note of that. We will have a technical help chat online in the near future to address and go more in depth with its questions. The recording and resources will be shared with everybody who's registered and participated. I want to give a big thank you to UNICEF colleagues, especially Radhika, who's been working to coordinate. Also to AKF, the AKF team, Joyce, thank you so much for joining us, Given, Josie, Christopher, and Mwanam Kasi and Naima. Thank you so much, everybody. Thank you so much. Have a wonderful and safe day, afternoon, evening, wherever you are. And we hope to see you again at the next webinar. Thank you, everyone.
Thank you, everyone. Bye.